Okay, people, we are going to focus on emergency contraception in particular in these few slides. This seems to be one of the best kept secrets ever. So we're going to unpack the secret so that you can all know it, so that you can help patients in future. Why won't it go? Let me just click on there. Okay, there. So as the gynae ambassador has already said to you, contraception is one of, if not the biggest women's health revolution ever, as in ever, literally ever. So it's hugely important for you to know what advice to give to patients, and emergency contraception is incredibly important to know about. As Kofi Annan, who used to be head of the UN, said, when women thrive, all of society benefits. And that's what this whole course is actually all about, is to help you help women to thrive. You cannot divorce human rights from women's health, reproductive health rights. Those are two completely interlinked, and I think you're starting to get an understanding of why that is. But when we're talking about women's reproductive health rights and access to contraception, we're actually talking about a fundamental human right. Now, why do I keep banging on about contraception being such a hugely important thing? Well, if you look at causes of death in young women globally, HIV is unfortunately still number one, even though it's preventable. And secondly is pregnancy related. So pregnancy, we think of it as a normal, happy, wonderful time, and it's physiological, and yes, can be all of those things, but it is the number 2 killer of women globally. And if you have pregnant teenagers, the incidence of mortality in pregnant teens is disproportionately higher compared to adult women. And we know that teenagers who might be involved in sexual intercourse, whether it is of their choice or not, that is a huge population that may need access to emergency contraception. So let's just have a look at what's really good in our country about contraception and what's a bit embarrassing. Okay, so contraception as a whole is freely available across the country, theoretically, and most women do know about it. But there are major systemic barriers and attitudinal barriers, which we're going to come back to. And emergency contraception, though it is freely available, in one big study, only 15% of women had ever heard of it. We're going to come back to that too. We do have much better care in pregnancy and labor than we used to decades ago, meaning that most women now deliver in facilities, so that's really good. But there's still drama there, and I'm going to show you just now. And we do theoretically have access to safe termination of pregnancy in this country. The service is legal, it's free, but we still have a massive, thriving business of illegal abortions. And you will learn more about this in the TOP section. Now, remember I said that women are delivering in facilities, and that's all rah, rah, great. This toolbar is right in front of, there we go. Okay, so Millennium Development Goal was to slash the maternal mortality rates across the world by 75% by 2015. Where are we now? 2020, okay, 5 years later, so literally not 2015 anymore. I'd like to draw your attention to, let's just take that out for a second. We are going backwards. We are literally going backwards in terms of our maternal mortality. There are only 3 countries going backwards: Suriname, which nobody has even ever heard of, and Guyana, which probably also people haven't heard of. Those are incredibly poor countries. We are a low to middle income country. So that is extremely concerning. The fact that we have such a high worsening maternal mortality rate in the face of the fact that women are delivering in facilities, we are spending money on healthcare, women are still dying from pregnancy-related complications. So we know that women with unplanned or unwanted pregnancies are also at a higher risk of mortality due to their pregnancy. So that is why contraception is so radically important. This is an epic fail. We have totally missed the boat, like the dinosaurs or the unicorns or whatever. We missed the boat on intervening and preventing unplanned and unwanted pregnancies with contraception. And there is no excuse for this. So why is it the case? When we think about emergency contraception in particular, but this probably applies to all of them. So access to the healthcare service, we know, is often a major problem in this country. HIV and the issues around certain contraceptives that interact with certain of the HIV medications is an issue. We know that economic status, which is often tied to level of education, are factors in how people access healthcare. And we also have a very, very nasty, terrible history in this country of the apartheid government wanting to regulate the birth rates of Black women, Black people. So contraception was used to control this population. And so for many people, there might still be an inherent suspicion of what this is all about. We've discussed in depth about how violence against women impacts on contraception. Women have far less control of their own reproductive health, so that feeds into it. We know that the healthcare system is flawed and faulty and overburdened. And there are many, many myths in the community about contraception, including emergency contraception. And then two things that I want to highlight specifically are that people are not educated about contraception at school. We're going to come back to that. And then there are issues about society and how society views women wanting to access contraception, and how we and our own attitudes as healthcare providers can influence this whole thing. And I know I keep banging on about it, but it's a fact. Okay, so what did you learn about contraception at school? You had a subject called life orientation. And whenever I ask this question of the students sitting in front of me, they'll say, like condoms, maybe something about the pill, maybe nothing, often nothing. So you're not getting the fundamental education about this radical health revolution that you actually need. It's the first problem. And a lot of you probably went to very good schools or schools that are supposed to have very good curricula, and you still came out of there not knowing much about contraception at all, despite the subject called life orientation. So essentially, you got crickets. And this, I think this is maybe a girl cricket, and maybe she's pregnant, and maybe it's an unwanted pregnancy because she didn't learn about contraception at school. Because we live in a very conservative country that doesn't believe in teaching teenagers about contraception or sex, because they think that that means you're going to go out there and have more sex and need contraception more. In fact, it's quite the opposite. The more you know, the more informed your choices are going to be, and the less room there is for error. And also, if people are going to have sex, they're going to have sex whether they know about contraception or not. So emergency contraception is one of SA's best kept secrets. There are essentially two methods that are popularly used. There is the high dose progesterone only pill version, and there is the copper IUCD. So let's have a look at a bit more. So what myths about emergency contraception are held by healthcare providers and patients? Probably the biggest one is that emergency contraception is the same as a termination of pregnancy, which couldn't be further from the truth. Okay, here's a nice little infographic. What emergency contraception does is it delays ovulation. Okay, so it prevents ovulation, prevents the little egg popping out into the tube, so then there's nothing to fertilize. Okay, so there's literally nothing to fertilize, so there's no zygote or anything to abort. That is the mechanism of action of emergency contraception. Okay. Whereas termination of pregnancy or abortion is the removal of an embryo or a fetus from the uterus. So there has already been fertilization, and now you are removing that product of fertilization. Emergency contraception, there's no egg, there's no fertilization. So it is not an abortion. Critical piece of information. This is a little cute little thing about what the emergency pill does. Hey boo, to the ovary, you've been working so hard. Why don't you take a break from ovulating for a little bit? And the exhausted ovary is like, that sounds really nice. So when sperm show up in the fallopian tubes, there's no egg waiting for them to fertilize. Okay. So general rules when we think about emergency contraception. It is safe. It is safe for everybody. A lot of long-term contraception has got certain contraindications. There are no contraindications to emergency contraception, particularly the oral progesterone version. There is no increased risk of anything. So it is perfectly safe, and it can be used as many times as a woman wants to use it. There are reasons why that's not a good idea, which we'll come to, but it's not dangerous to her health in any way. Another crucial rule is that it's got to be used as soon as possible, preferably within 12 to 24 hours. With the oral progesterone, you have a 3-day window, and with the IUCD, you have a 5-day window. And after this has happened, a woman should obviously leave with a long-term method, because she is sexually active and clearly she's had unprotected sex, so a lot of conversation is going to have to happen around that, unless of course she's been raped, and that's why she's on emergency contraception. Maybe she's not in a long-term sexual relationship, but most of the time you're going to want to counsel your woman about being on a long-term method. Okay, so the progesterone emergency contraception can be obtained without prescription. That's been since the year 2000. It can be offered to a woman of any age. It's a once-off dose, and like I said, there are no contraindications to the oral version of emergency contraception. They're very safe. They do not impact on health. They do not impact on fertility. Okay, so those are a lot of myths that people have, or, you know, that it's harmful, it's damaging, you shouldn't use it because it can cause long-term problems. That's all nonsense. So what information or counseling would you ask or give to a woman who is coming for emergency contraception? So before providing, you need to make sure that she's not already pregnant, because that is a possibility. Not that the progesterone is going to harm the pregnancy. Certainly an IUCD could interfere. But if she is already pregnant and she clearly doesn't want to be pregnant because she's come for the emergency contraception, then you're going to have another conversation, which is a potential for a termination. Okay, you have to explain the side effects, which for the oral pill are the most important one is nausea and vomiting. So if a woman vomits up all the tablets, she might need to have another dose coupled with an antiemetic, or you might want to prescribe an antiemetic with it to prevent the tablets from being vomited up. And then remember, this is a progesterone pill, and you're going to give it, and it's a once-off, and it's a very high dose. And the minute progesterone in the body stops being secreted, there will be a withdrawal bleed. So now you are giving an exogenous, very high dose of progesterone, and then you're essentially immediately withdrawing it. So she is going to have a withdrawal bleed. So you need to warn her that she's going to have a period that's out of her normal cycle. There could be drug interactions with the oral one if she's on other medications, some of the enzyme inducers. And if she is already on the pill, she must pick up from where she left off and continue as normal. Sometimes somebody will forget 1 or 2 pills, and then they might need emergency contraception. That's fine. They will then go back onto their pill, but with the understanding that they will be unsafe in terms of they might fall pregnant until they've been on their pill every single day for 7 to 14 days, depending on the pill. Now, all contraception has a failure rate. Even a tubal ligation has a failure rate. Similarly, emergency contraception has a failure rate. So if she does get the emergency contraception and it doesn't work, then she might need to come back, and then the discussion is about, okay, does she still want to not be pregnant, or does she want to continue the pregnancy? And then she might need to be assisted for TOP. And she must return for a pregnancy test if she hasn't had her normal period around about when she would expect it, because if you're not having your period around about when you would expect it, you could obviously be pregnant. And then you need to discuss the risks of STIs. Okay, obviously she's had an unprotected sexual encounter, and she needs to have the discussion about HIV, about barrier contraception, the risk of other STIs. Now, the IUCD is the most effective method. It's much more effective than the pill, but not everybody's got the skill to insert this. So that's one of the drawbacks. And there are some contraindications to this, although most women can have an IUCD. So there are the contraindications. So the pill, the loop, the copper IUCD, can cause heavy bleeding and quite bad dysmenorrhea. So if somebody comes in and they've already got that in their gynae history, this is not going to be a good method for them. So if there is the skill and the possibility for this, it's an excellent solution, because it also gives you now a 5-year contraception like in situ, and she doesn't have to keep coming back for another method. So that's the really big benefit. Plus it's more effective than the pill. You might want to be careful in a woman who has potentially multiple sexual partners or has got signs or symptoms of PID, because this can aggravate that, but that's not going to be the majority of the cases. Okay, some golden rules when it comes to emergency contraception. Number 1, if they want it, they get it. Finished. And that is even if the partner is going to the pharmacy on behalf of the woman to go and get the emergency contraception, it by law has to be dispensed. Okay, so if a woman wants emergency contraception, she gets it, finished, whether she's on the pill or not, or whatever the circumstances are, no arguments. Most pharmacies will have a little form where they go through the questions to make sure that it is appropriate. And I promise you, it's never inappropriate to give the oral version. Some pharmacies will have a rule, which is actually not legal, that if you've come to the pharmacy 3 times in a row for emergency contraception, they will refuse to give you emergency contraception thereafter. Now, that is illegal. It's not allowed. She can have it as many times as she wants. It's not ideal, and I'm not advocating this, but it's not right to deny someone something that has significance to their own reproductive health. So why shouldn't the emergency contraception be a recurrent use or a method of use of contraception? Well, because it's not as reliable as other options. Okay, so that's the biggest issue. You're not wanting to be pregnant and you're using a less reliable method to not be pregnant. That's the first problem. The other problem is that when you do give the hormone version, the progesterone, you are going to have an impact on the cycle. So that's not going to change your fertility, and it's not irreversible, and it's not damaging. It just might make things unpredictable, and then you might not know when to expect your cycle or when you're going to be ovulating. And of course, the higher, when you're giving emergency contraceptive, the oral version, the hormones, you're giving a much higher dose than, for example, the oral contraceptive pill. So there's a higher chance of the side effect, the vomiting, which then is counterproductive. And actually, the emergency contraception, if you keep taking it, it ends up being more expensive than a regular form of birth control. So golden rule number 2, and I keep saying this as well, is please reserve judgment when patients come to you with issues like this of a sexual nature. I remember I once had a UCT. She was a social worker student in her 3rd year, so tons of access to information. She already had a 9-month-old, which was unplanned. And now she was coming for a termination of pregnancy because this was her 2nd unplanned pregnancy. And I asked her, well, what form of contraception have you been using, if any? And she said, oh, I use the emergency pill when I need to. And internally, I wept because I thought, this is an educated young woman. She has got access to thousands of computers, the whole of Google, and this is still the situation we're in. And I said to her, well, have you ever thought of being on a more long-term solution? And she said, yeah, but you know, at home, people say things about the injection, and I don't know, I wasn't sure. So she still had this very deeply ingrained myth about contraception. So I was extremely frustrated because this was a totally avoidable situation, but that's my problem. My frustration is mine to own. You've got to suck it up and have your poker face on and non-judgmentally deal with the situation in front of you. So as I keep trying to explain to you, you are going to have feelings where patients annoy you. You're annoyed at how they've treated their own bodies or what they've done or the kinds of behavior they're engaging in. That is their life, and it is not your job to judge that. It is your job to be as objective as possible and be the healthcare practitioner. It's not always possible, but you have to try. So yeah, we've discussed this as well, that when you're discussing matters about sex, there's always a stigma and a drama and a morality that comes with it. And that little dog is very embarrassed and the cat is horrified. And that picture is to illustrate some of these quotes that I'm going to read to you, which are from research papers. The attitude of health staff serves as a significant barrier, especially for young women. This is now young women going to get contraception. Young women trying to access free condoms from clinics choose never to return because of the judgment and scolding of clinic staff. Contraceptive use is associated with a culture of fear, shame, and poor morality rather than responsible and healthy sexuality. And I think for a lot of us, if we have to ask deep down what we think about teenagers having voluntary like sexual intercourse or multiple partners or whatever, it'll touch buttons because we have grown up in a very conservative country. But it's not for us to judge because this is exactly what ends up happening. The person turns away from the healthcare system, and then there's an unplanned pregnancy, and then there's any number of consequences for that woman or the child. There are frequent reports from contraceptive clients about the negative attitudes and rudeness of service providers towards them. Okay? Women regard quality of care, including the way in which people are treated, as the most important aspect of contraceptive service provision. Mind blown. But I'm not that surprised. You might be, but this is what I keep saying to you, is our attitudes and the way we engage with patients is so potent in terms of how that interaction is going to play out. Commonly requested specific changes to services are that staff should be more understanding, more available for explanation and counseling. Clinics should have longer consulting hours, greater accessibility, reduced waiting times, and more privacy. And the provision of adolescent-friendly services is a need identified by young people. Because like I said, young people are experimenting. They're going to have sex, whether we want them to or not, and we actually need to support them to make healthier life choices. So yeah, a lot of religious, cultural norms, our own personal experiences are all cooked up in every consultation that we have with the patient, but we need to learn to leave our own stuff at the door when we are sitting in front of someone. Because you and the woman are on either side of this consultation, and the most important person in the consultation is your patient. It's not you. Okay, so the main thing to take away from all of these quotes I've given you is that a single interaction with the patient, and I mean any patient, I'm not only talking about women's health here now, a single interaction can change a woman's entire life through either being empowered by a trustworthy, empathic person, or being completely disempowered and then mistrusting the system forever. And that is the burden of our responsibility as doctors. So my final words to you in this slide presentation are that if we get contraception right, we basically save the world. So please shout it from the rooftops. That is why your assessment for this online block is about contraception because it is so fundamentally important. All right, let's go out there and get people on contraception that works for all of them. And now I need to stop the recording.